Hello people, in this video let us try to solve the orthopedics final year question paper and see if you will be able to answer. Now the first question, first look at the question paper pattern here. You have long essays. Long essays are for 10 marks. In orthopedics they are giving you only one long essay, and here no, they are giving you two long essays, so 10 into 2, so you have 20 marks there. And then you have short essays, that is 5 marks each, okay, and you have 3 here questions. And then you have short answers. Short answers are 3 marks each, guys, focus here, and you have 5 questions, so that will be around 15 marks. So this will add up to how much? 50 marks. Okay, let us focus here. What as a suggestion I would say is always in the exam solve the short answers first, okay, because very quickly you'll in first half an hour, okay, or first 15 minutes you will be able to get this part over. Okay, just writing 6 lines will give you 3 marks and probably a small diagram. So this is, you get this off the chest and then come to the short essays and then come to the long answers. So that is what is my suggestion. However, if you have any other plan, you can do that too. So let's practice what we preach. So let's get started with tennis elbow. What is tennis elbow? You should be able to tell, right? You have already seen this in our video. So it is also called as lateral epicondylitis. So what are the bones here? You have the humerus, you have the radius and the ulna. Radius here and the ulna in the medial side. So basically these are the bones, and that is forming your elbow joint. Now there you have something called as the lateral epicondylitis. So you can just touch your lateral epicondyle, right? Something to do with that itis. So is this something to do with the bone or the muscle? Because how can you say it is epicondylitis? Something to do with the bone? Lateral epicondyle is here, and there is a tendon, injured common extensor tendon. So that is where the muscle is coming, and tendon. Okay, so just say it is inflammation of extensor muscles of the forearm, guys. This much is enough. Extensor muscles. Which one? Extensor muscles. Okay, so not only in tennis, people who wriggle clothes, lift weight, hammer use, all those people will have this. Okay, so you should keep the forearm pronated. This itself is forearm pronated, right? Now what you do is you flex the wrist and fingers. Wrist and fingers you flex. Keep the arm straight. Okay. Flex the wrist and fingers if there is pain. So that will be the way of saying that there is, what do you say? Lateral epicondylitis. Okay. So X-ray will be normal. This is something that you have to tell them. X-ray will be normal because there's nothing to do with the bone, isn't it? And movements are also normal. Only pain is when you are putting the extensor tendons to a stretch. Okay. So basically, what are the differential diagnoses that also you can write? It can be golfer's elbow, arthritis. So golfer's elbow is something to do with medial epicondyle. Student elbow is because of always keeping on the table while writing. Olecranon bursitis also it can be. So these are the two DDs. Okay, don't forget. What are the 2 DDs? One is that come on, say what did I say? Golfer's elbow and the student's elbow. Very good. You should know, one is medial epicondylitis, the other is olecranon bursitis. You got it right? Very good. You should write that. Quick points for quick marks. That's what I'm saying. Then how do you test it? Wriggling test. If they do this, they will have pain. Cousins test. Cousins test. With the forearm pronated, ask the patient to make a tight fist. Yeah, pronated, and you are asking them to make a tight fist. Yeah, that will give them pain. Right? Again, pain will be felt at the lateral epicondyle. Okay. Then how do you treat it? Ask them to rest. What do you say? Why give analgesics? Okay. Analgesics, anti-inflammatory for a drugs for a week or so. That's it. An injection of hydrocortisone is typical standard orthopedic stuff. This is okay. Tennis elbow, basically depot preparation of hydrocortisone, metronidazole. Same thing. You will give local injection. That's what they are saying. Manipulation for the pain relief. What is this manipulation, guys? Focus. Okay, that's it about the tennis elbow. This much if you write, definitely you will get 3 marks. Now, next we'll go to anterior drawer test. Anterior drawer test sounds more like knee joint, right? What do you say, people? What are you trying to check in anterolateral drawer test? This is anterior drawer test. They've asked only anterior. Well, they're going in the sequence explaining to you very, very nicely how you should lie and how you should be flexed the knee at 90 degree. Then the patient should be lying flat on table. And the examiner should grasp the knee, how to grasp, and then now you gently pull the tibia forward anteriorly while observing how far the tibia moves. Okay, that is anterior drawer test, but we need more technical details. When you will do it, why you will do it, what are the findings. Got it. So it is basically a test to determine the injury in the anterior cruciate ligament. Okay. So look at this, people. Basically, normally there is a glide up to half a centimeter. Anything more than that will suggest anterior cruciate ligament laxity. Okay, that is what you have to understand. Okay. If you are drawing anterior cruciate ligament, you will get more marks. So draw this. Okay, it is very simple. How you will draw? Draw ligament like this. Like this, because if you're indicating right knee, right, anterior cruciate ligament show like this. This will be your femur and this will be the tibia. Okay. So you should remember, at least in right leg, that how the direction is going, right? Like this. Are you able to see what I'm drawing? Like this, right? So from lateral on top to medial at the bottom. That is how it is going for right leg. Okay, that's what you should remember. For 3 marks, this is enough. If you want to say more, you can say how it gets injured, how to treat, etc. Okay, or generally add, okay, it'll happen in athlete sprain, it'll because of a sprain, etc. And how do you treat? Rest, rehabilitation, knee brace, etc. Okay. Just look here how internet says, okay, the treatment will be surgery. Sometimes you can have physiotherapy. Basically, first you tell all the conservative. Then when it comes to surgery, they're talking about ACL reconstruction, arthroscopy, etc. Okay. See, why I don't know why they're putting surgery on top. You should always put surgery at the last, right? So first you will say rehabilitation, physical therapy, physiotherapy, elastic bandage, knee brace, etc. And then finally you will talk about arthroscopy and ACL reconstruction. Okay. Okay, so here we are. We have finished how much now? So we finished tennis elbow and anterior drawer test, right? Now let's go to the third one. Here, that is the Thomas splint. Okay. Here they have shown you Thomas splint with the pulley, etc. But without the pulley, you can imagine in the emergency the patient is brought in, right? So this is how it is fixed to the lower limb. So you can see here there's a ring, right? There's a ring here. Are you able to see the ring? Where's the ring here? So this is the ring, right? So this ring is the one that you have to insert into the lower limb, which is very painful. So what is the indication, guys? Suspected femur fracture. Very good. So look at this. It is also called as, the full name is Thomas knee bed splint. Okay, by H.O. Thomas. It is common splint. Okay. So you will use it for immobilization of hip and thigh injuries. So the angle, remember, is 120 to the inside bar. You have to draw this diagram in the exam. One ring here, one line there, and one slight bent and a line here, and then a notch here. And this is 120 for the inner bar, and the ring, the angle. Okay, this is very important for you to know. So the ring size is important. So based on the patient size, you'll have to choose the Thomas splint. Okay, you have a lot of sizes there. And how will you measure the length of the Thomas splint from the highest point on the medial side of the groin up to the heel plus 6 inches? To me, it looks like whatever is what you need plus 6 inches you should add. Okay, that's what it looks like. So the medial side of the groin, the highest point to the heel plus 6 inches. Okay. So you should be able to differentiate it from the other splint, that is Böhler-Braun splint. Okay, you can see this here. It doesn't have a ring. Okay, that is very giveaway for you. It doesn't have a ring. One more question finished. That's great. Let's move on. Popliteal cyst is the next question. People, are you focusing here? This is the next question. Popliteal cyst. So it is nothing but Baker cyst. So you can see here in the right knee, you are seeing here at the back in the popliteal region, there's a cyst, there's a lump, that is the Baker cyst also. They are calling as Baker cyst. So basically the synovial membrane, right, there is some herniation. So it can be because of osteoarthritis or rheumatoid arthritis, right? So it is also called as Morant-Baker cyst. So you can see that word here, Baker cyst. So basically you can aspirate this fluid, or this may rupture and it can leak, the fluid can leak into the calf, right? That is the muscles below. So you can also do arthroscopic excision of this lump, okay, or this cyst. Fine. How's it going, people? Now let's do one thing. Let's move to the next question. So the next question is, what is the next question? Galeazzi fracture. Okay. So this Galeazzi fracture, you can see fracture of the forearm, again on outstretched hand. If you fall, you will have. So what do you see here? You can see that the thumb side is fractured. That means the lateral, which bone you have? the radius, right? So the radius fracture, and the radius fracture, which is the distal part of the radius, right? The distal, this is proximal part of the radius. So the distal part of the radius here is fractured. So that is what you should know here. The lower third of the radius is fractured, okay, with dislocation or subluxation of the distal radioulnar joint. Okay, so the distal radioulnar joint is subluxated. Okay. So this is the counterpart of the Monteggia fracture, which is, what is Monteggia fracture then? Monteggia is actually where the ulna is broken. Okay, so here actually the radius is broken, and that to remember, the distal part of the radius is affected. Okay, so just see near the thumb you hit, near the thumb you hit on your radius and say Galeazia. Okay, so look at the X-ray image here. X-ray of the forearm showing the AP and lateral views, the Galeazia fracture dislocation. Note the dislocated distal radioulnar joint. Okay, so are you seeing that the radius is broken? That is what is the most important thing. So towards the thumb you can see the radius is there, right? Are you able to see towards the thumb? So here this is the thumb, this is the radius. So you can see the distal part of the radius here is broken, and the ulnar joint, which is distal, the distal radioulnar joint is subluxated. Okay, so this is what is Galeazia fracture. So remember people, you will always what will you do is treatment, reduce and fix, right? That is standard treatment in orthopedics, right? Reduce and fix. Then what is the complication of this? Anytime you will write malunion. So we are done with short answers. Now let us move on to the short essays. Okay, so what are we looking at? Just take a recap. We are looking at the orthopedics final year question paper. So we have looked at the short answers. Now let us move on to the short essays. That is 5 markers. 5 markers, they are asking wrist drop. Let us look at wrist drop first. Main thing you should know, wrist drop means what? The wrist has dropped. Yes. So which nerve has been affected? Yes, the radial nerve. Okay, this much if you know, that the radial nerve has been affected. That's why there is a wrist drop. Okay, you can see here my wrist is dropping because my radial nerve is not working. Now why the radial nerve has been affected? So this can be a Saturday night palsy where there's just compression of the nerve, etc., or there could be a fracture. This is orthopedics, so they are asking about fracture. Which fracture? So we look at our own video notes. So here you have radial nerve palsy where it is dropped. So you can see the path of the radial nerve. It is coming from the posterior cord of your brachial plexus, right? That's what I am thinking. Then, so it is going here. It is medial to the humerus. Then it is going in the spiral groove, and it is coming lateral to the humerus. The distal part of the humerus is lateral to, and then it is coming here in the cubital fossa. Okay. So what happens? The roots are C5 to T1. Okay. Then it is supplying some long head of triceps, medial head of triceps. Okay. Then when it comes to, that is the arm, brachialis, brachioradialis, etc. When it comes to the forearm, it is supplying all these extensors. Extensor carpi, radialis, brevis, digitorum, digiti, minimus, carpus, ulnaris. So many extensor muscles I can see here that it is supplying. Okay, and in the hand it is just supplying some parts. We'll show you that. So very small part on your palm, and in the dorsum of your palm it is supplying these thumb, etc. Okay. So anyways, what exactly is causing the wrist drop? So basically the wrist will remain in palmar flexion because of the weakness of the dorsiflexors. So this is seen in radial nerve palsy, which can happen because of the compression of the nerve, because if you are drunk and you are sleeping, or a honeymoon palsy where one person is lying on the other's hand. Okay. So the other thing is fracture, because this is orthopedics, right? So this is orthopedics. So what is happening? The fracture of the shaft of the humerus, that will cause a wrist drop. So this is also called as Holstein-Lewis fracture. There you can see that there is a spiral fracture. Are you able to see here? There is a spiral fracture. So because of which the nerve is affected, right? The radial nerve injury will result in the paralysis of the wrist, fingers and thumb extensors. Okay. So this is the wrist drop. So also other causes are there, like we told you, the pressure, or there could be toxic agents, injection tetracycline also, which can result in radial nerve palsy. Okay. So radial nerve palsy is because of the paralysis of the extensors of the wrist and the metacarpalophalangeal joints, right? MP joints. So what is the splint that you use? You'll use a cock-up splint. How does that look? Cock-up splint. So this is that cock-up splint. Okay. So muscles they are focusing on. The muscles are extensor carpi radialis longus. So radialis is there in the name. Remember, long radialis longus, carpi, extensor carpi radialis longus looks like is affected. So here they are telling that even the extensor digitorum is affected. Okay. So in wrist drop, extensor digitorum is not working. This is what you have to focus on. So what are the tests to check for radial nerve palsy? High radial nerve palsy, low radial nerve palsy. You have to check. So how will you treat this? So you have to decompress. So you have to just wait, give the nerve which is compressed to decompress. Then you can, other treatments they're talking about is you have to fix the fracture, etc. Right? Then you're also talking about tendon transfer if it is required. Right? So because this nerve is not working, you'll have to transfer tendon from one place to the other. You understand? One muscle you will connect to the other place. Are you focusing, people? So these are the following tendons which are used. If you want, you can remember this. So this is the cock-up splint. So these are the treatments of radial nerve palsy, wrist drop. Considering that it is 5 marks, I hope that we have covered enough for you. Okay, so where are we now? Osteoid osteoma we have to look at, right? Let's look at this now. Osteoid osteoma. So as soon as you say osteoid osteoma, what comes to your mind? Tumor of the bone. Sounds more like a benign condition, right? So let's look at that. So here you have the benign conditions on the side. So where do you see your osteoid osteoma? Here. See here in the diaphysis here. Can you see osteoid osteoma has been written? So let's zoom there. Osteoid osteoma in the diaphysis. So they have written here it is bone forming. So look at the osteoid osteoma diagram. It is bone forming. Benign tumor of the bone. Most commonly, where do you see it? In the femur and the tibia. Okay. So are you able to focus here where exactly the information is here? The most common site of osteoid osteoma, okay, of osteoid osteoma is femur and tibia. Okay. And what is its counterpart? In the malignant version, it is called as osteosarcoma. Okay. So focus here. You just imagine a Mr. India type of male. Okay. He has a pain in the femur, tibia, that area, knee area, this night pain which is relieved on aspirin. So that will indicate you osteoid osteoma, bone forming, okay, it's a bone forming tumor. So here you can see here, it's written here, osteoid osteoma, 20 to 30 years old people, Miss India, Mr. India types of people. So night pain relieved on aspirin, okay. So the counter malignant part is osteosarcoma. But people, it is for 5 marks, right? So what more you have to explain? So you have to tell that pathologically it has a mineralized osteoid trabeculae. That is what new bone, right? And it will affect mostly your tibia, femur tibia area. So it will affect the diaphysis of the long bones. Did we read that? Yes, diaphysis. Yes, diaphysis it will affect. Okay. So there is pain which is worst at night, which is relieved by salicylates. This also we told you. There's a palpable swelling. Okay, sometimes there's a palpable swelling. If it is a superficial lesion, you can diagnose using X-ray. So you'll have to excise this, right? Excise the complete thing, the nidus along with the sclerotic bone. Prognosis is good. It is not a pre-malignant condition, so it's not going to become a sarcoma. This one is not going to become, okay. Only this much information is there in the textbook about osteoid osteoma. For 5 marks, you have to just draw diagrams and just elaborate with lot of fillers. Okay, that's all we can say. Now let us look at this question, loose bodies in the knee. Okay, this one, loose bodies in the knee. This we have already studied in our videos. Here you can see a loose body, right? In the knee joint here, you can see one loose body. So basically it is most commonly seen in the knee joint. So this is nothing but an osteophyte. Okay, that is a bony lump, bony spur. So, what is causing this is osteochondritis, osteochondral fracture, synovial chondromatosis. In synovial chondromatosis, the number of bodies is more than 50 to 60. So remember, synovial chondromatosis. So basically, this is non-cancerous benign tumor affecting joints like your knee. So the tumors develop in your synovium. Okay, in the synovium, that is the membrane they're talking about, the thin layer of tissue that aligns your joints. Okay, so it can cause these loose bodies. So chondro usually refers to your cartilage. So it is forming cartilage and then that is ossifying, is it? So basically it is producing these kind of loose bodies. So remember, around 50 to 60 loose bodies you can find in synovial chondromatosis. So here you can see the loose body, and what will happen because of this? So there will be pseudo locking. That's what they are saying. What will happen? There is sudden, because of pain or something, sudden locking of the joint. This is pseudo locking, they are saying. And also the patient can feel some loose bodies inside. Okay, and in the X-ray you can find that there are loose bodies. So what will you do? Either orthoscopically you will have to go and remove these loose bodies, or you will have to open up the joint and remove the loose bodies. So here you can see that in knee joint it can happen in shoulder joint, it can happen in ankle joint. So basically remember, loose body will cause pseudo locking. Okay, that's what you have to, who will cause true locking then? Hamstring spasm, osteoarthritis, etc. To get marks, better draw diagram. So do you know how to draw diagram? That will fetch you marks. Always practice of this knee joint diagram. Okay, lower end of femur, how to draw, then one tibia, how to draw. Okay, and then next to it one fibula, how to draw. This much if you practice off. Okay, this is my fibula. Okay, and one synovial membrane here. Okay, knee joint, if you practice, no, in the exam you will be able to pass. So one cartilage you draw here. Okay, and fill this with some fluid. And here there are some ligaments. If you want, you can show one ligament. Wait, we'll draw ligament in green. The anterior cruciate ligament. Okay, anterior cruciate ligament, and behind you can draw the posterior cruciate ligament. So this just joint and labeling the parts might get you a lot of marks. So draw this as, so label this as femur, lower end, and this as tibia, and then this is fibula, and then tell them that this is the right knee joint from anterior view. And then here you have the loose bodies. Loose bodies you can show like this, right? Which is visible in the X-ray like this to get marks. So this is the anterior view without the patella. So look at it and draw this in the exam. Okay, people, this diagram can get you a lot of marks in orthopedics. So practice this. Okay. So people, hooray, we are done with short essays. Now let us look at long essays. So they're asking you about the compound fracture of leg. Compound fracture of leg. What do you mean, first of all, by compound fracture of leg? What is leg? Leg is composing of your tibia and fibula, correct? Mainly. Above knee joint, below you have ankle joint. Okay, so focus here. What do you mean by compound fracture? Compound fracture is nothing but open fracture. Open fracture can be either internally open or externally open. Okay, so basically you remember here, this is leg and they're asking you about compound fracture. What is the main problem in an open fracture? Osteomyelitis infection. So we are just looking at the high level here of open fracture. So try to close it and make it a closed fracture, or then you have to give this emergency care, that is what is that? Immobilization, right? Arise, that is rest, ice, compression, elevation, all that they're talking about. Then you should do wound care, you should put splint, you should give prophylactic antibiotics, you should give tetanus prophylactically, you should give analgesics as painkiller, then you should also give, you should do all the x-rays, etc. and keep ready. So that is the emergency care they're talking about. Definitive care, they're talking about wound debridement, fracture management, skeletal traction, skeletal fixation, internal fixing, etc. Then you have to rehabilitate these people so that they can walk again. So here, because you're talking about the leg means you have to cover the fractures of the tibia and the fibula. I think the main thing they want you to focus on is the compartment syndrome, which can happen because of these fractures, okay? They've shown you how to reduce the fracture, right? Some techniques they have shown here. Wedging of a cast. So why are you doing this? Corrected. The angulation is corrected. For open fractures, there's some grading, people. Grade 1, grade 2, grade 3, this you should know. And they are telling that the latest is that grade 1 and grade 2 are being fixed internally. Okay. There is some patella tendon bearing cast, is it? So this and all you should know. And look at this diagram here. Femister grafting. So in treatment, they are talking about nailing with bone grafting, femister grafting. And then you have this Elizarow's method, right? So here you can see the Elizarow's technique. See what they are exactly doing here. See, they are cutting the bone, okay? Just look here. They themselves are cutting the bone in a place where it is not cut, okay? This bone gap which was already there, that they are closing it, okay? And they are allowing the bone to form, new bone to form, where they have cut it. So this is a very interesting technique that you should know, okay? Elizarow's technique. So again, the drawing diagrams will help you, okay? That's the only way to clear again this 10 marker. Hooray people, last question. The etiology, clinical features, management of CTEV. What is CTEV? Congenital talipes equinovarus, right? So as soon as we say congenital, you know it's something to do with the baby. So you can see here it's also called as club foot, the way it looks like a golf club. So what are these terms, right? What is talipes? Talipes is ankle and the foot. So that is basically what is affected, the ankle and the foot. So equinus. Equinus is where there's exaggeration of the plantar flexion. Guys, focus here. The exaggeration of the plantar flexion. Why it is? It is because of the contracture of the Achilles tendon. Okay. So then you have equinovarus, right? What is varus? Varus is medially rotated, okay, because of the contracted tibialis posterior. So this is medially rotated. Are you focusing here? So there is an exaggeration of the plantar flexion, and there is a medial rotation, that is the varus. So equinovarus. And then you have cavus also, that is high arched foot, okay, because of the contracted tibialis posterior. Same contracted tibialis posterior has been blamed in both of these. And here they have blamed the contracture of the Achilles tendon. So basically, what are the causes? Intrauterine compression, some nerve problem. So it could be neurogenic. It could be a vascular abnormality. The bone itself could be having some problem. The muscles could be atrophic. The ligaments can be shorted, contracted. So basically, the causes itself they're telling is idiopathic, neurogenic, that is because of the nerve, syndromic, probably, which affects your muscle, bone, and your ligaments, right? Or vessels. So dorsiflexion test is there to distinguish a normal CTV from a true CTV. And then in the kite's angle in the X-ray, you can see that the angle is reduced. Okay, which angle you have to check that? The angle in CTEV is less than 25. Okay. Okay, it's the reduced talocalcaneal angles. Okay, reduced talocalcaneal angles. Yes, actually in the etiology, in the textbook, they are giving a lot of theories: mechanical theory, ischemic theory, genetic theory. Then in secondary clubfoot, I think that is happening later on because of paralytic disorders. Some AMC, arthrogryposis multiplex congenita, is a defective development of the muscles. Okay, so this is the examination. Now, how do you treat, right? We'll have to look at this manipulation. Ponseti technique is there. How will you correct? First, you will do the cavus correction, then the adduction correction, then the varus, and then the equinus. Equinus is corrected last. So you have CTEV shoes, then Dennis-Brown splint. Dennis-Brown splint is worn even at night, remember? Okay, so you can see the CTEV shoes, how they are different. So straight inner border is there, and then there's outer raise, and then no heel in the shoes. Okay, so outer raise, straight inner border. These things you should know. So then they are talking about surgical management, Z-plasty of tendo-Achilles. Okay, so because this lengthening of the tendo-Achilles is required, so they're doing Z-plasty. So that is what they have explained here in the diagram also. Then you will do some soft tissue release, postero-medial, then posterior capsulotomy, tenotomy, tendon transfer. Tendon transfer you'll write for almost everything where the muscle has problem, right? Because of the nerve also, but if the muscle is not working, you can talk about tendon transfer. Then they're talking about the surgical bone. After 4 years, the calcaneus has to be fixed because what is wrong with the calcaneus? They are removing some part of it. Open wedge, Droyer's osteotomy. One more surgery to the calcaneus, distal calcaneal osteotomy. This is called as Lichblau surgery. Then you have something where they are fusing two bones, not removing exactly. They are fusing two things. That is the calcanocuboid fusion. This is called as Dillman-Evans operation. Please focus. Dill heart. You're joining two things. Calcanocuboid fusion, okay? Dillman-Evans. And about 10 years, they're talking about this triple arthrodesis. Please, you have to focus on this triple arthrodesis. What and all are they fusing? The bones involved are the talus, calcaneus, navicular, and cuboid. And they're joining, I think, with 3 joints. The talus and the navicular, the talus and the calcaneus, and the calcaneus and the cuboid, is it? I think the 3 are labeled here. Subtalar joint, talonavicular joint, calcanocuboid joint. Okay. I called this as the tallow and calcaneal. No, they're calling it as a subtalar in this diagram. Okay, so we have covered CTEV. There's a lot more that you can write, draw diagrams to get marks. Okay, basic key concepts we have told you. So this is how you will pass your orthopedics exam. This is how it will look, your question paper. So we have revised a lot for you. Hope you will study more and pass. Bye bye.